All right, good morning, everybody. This is Anna Jenkins, Marketing Coordinator at Core BTS, and welcome to today's webinar, Data Leakage in Healthcare, How Your Data is Leaving Your Organization Without You Knowing. Throughout our presentation this morning, we encourage you to interact with us by typing in questions and comments using the question and answer pane in the WebEx Event Center. We'll be answering questions live both during the event and after the presentation. We're also recording today's session, and we'll send a link to the recording after the event via email. Today on our panel, we have Matt Wilson, our Managing Consultant for Core BTS's Security and Compliance Practice. And at this time, I will pass the ball along to Matt to get us started.
Great. Thanks very much, Anna. Thanks to everyone who jumped in today. I know it's summertime, so it's tough to get people to actually show up. It's vacations and a lot of probably work trying to be crammed in between vacations, so thank you again. As Anna mentioned, our focus here is around data loss prevention in healthcare, and you know, we work with a ton of healthcare organizations, and it's something that commonly gets asked of us is how can we prevent this? And as you'll see, and something we'll touch on that's pretty obvious, is there's no 100% foolproof way to do so. But I'm hoping today we can take a couple minutes and have some interaction and maybe explore some strategies to help reduce some of that risk. So as Anna mentioned, I head up our security and compliance practice for Core. I'm based in our Philadelphia area offices. We have two, one in Wyomissing, Pennsylvania, one in Exton, Pennsylvania. And we end up supporting customers throughout Core's footprint. And that really is, while for the most part, east of the Mississippi, we have offices in Minneapolis and so on. And we actually have customers that have international offices. So we end up going where our customers need us to be. As a practice, we really focus on the strategic consulting side, things like security assessments and risk assessments and technical penetration testing and application testing. Because of that, we end up working with a lot of folks that have regulatory requirements, such as HIPAA. And while I've been at Core for 8 years and we've worked with folks from really every vertical, the last 3 years or so, we've seen a huge uptick in interest on within our healthcare client base around just improving their security posture. So that was some of the inspiration for having this conversation today. So to kind of get some of the juices flowing, so to speak, please, as Anna mentioned, use the Q&A panel or even chat, but Q&A tends to be best. I'd like to just ask the folks that are here, you know, what are you looking to get out of today? You knew you were coming to a webinar, it had something to do with healthcare, had something to do with data loss and preventing that. So what would you like to see us touch on, or what were your expectations of things that we would touch on today? And I'll give it a good, you know, minute or so to let folks chat up their answers. And keep in mind, there's no right or wrong here. It's just what you were expecting to see. And if we get nothing, that means Anna and I have to make some things up. So please do input whatever you have on your side. No one's feeling very frisky this morning to participate. There we go. Thank you, folks. It's all flowing at once. Great. So, okay. Okay, so there's some concerns about, hey, I want to gather some information and not miss anything. There's some questions about some major data breaches in healthcare. What does that actually mean? Something we'll absolutely touch upon. Folks really just looking for protection of data, or you know, how folks might be, you know, using data. I'm assuming by when you mean secondary and tertiary uses of data, you mean how the good guys and the bad guys could be doing such a thing. So great. Well, thank you all very much for shooting that over. And again, I can bludgeon you with PowerPoint today, but I'd rather not. I'd rather have an interactive conversation if we can. We're a little bit limited in terms of typing back and forth, but it's gone pretty well in past webinars, so right, once it slips out of our controls. That's a great point, Max. So well, actually, believe it or not, I can't promise I was going to cover it to the extent that everyone maybe thinks or had thought of when posing the question, but that's actually quite a bit of the game plan today. The presentation and conversation is already geared towards hitting on all that. So good news. Sounds like we are all of the same general mindset here. So a quick overview. I want to talk through knowing what your PHI is and ePHI, how it's actually getting out of environment, data breaches and what they've meant to the industry, talking through some of the regulator reactions to that, things that we've seen really. HIPAA was passed in 1996, but it hasn't been for the last couple of years that you've really seen a strong response from Health and Human Services and the Office of Civil Rights. There's been a handful of fines over the years, but it's really the last 3 or 4 years or so that you've seen them really pay attention. And even a little bit more restricted than that is the last 18 to 24 months. Talk about how you can rise to the challenge of preventing data leakage and addressing security incidents. And we'll talk through some next steps, at least as we see them. So I'd like to kind of start with a theme almost and set some goals for today. I really wanted to leverage some of the recent data breaches and our experience in healthcare to talk about an informed approach to reducing breach risk. Again, we're not going to make it zero, but if we understand some of those human factors and we acknowledge some of the common InfoSec processes and where they might be strong or weak, and some of the tool sets that exist that you may or may not have or may or may not even have budget for, you'll hopefully be able to take some things that you can and integrate that into your security plan. Again, there's no perfect here. So quick fun exercise is, it's 11 a.m., do you know where your data is? And obviously it's partly tongue-in-cheek here, but that's something that we found a lot of organizations don't really have a strong sense of where their data is. I'm not asking for you to chat in a public forum where all of your sensitive data is, but how confident are you in really knowing where all of the data is? It's something that when we get into security assessments, a lot of times we ask questions and initially there's a lot of confidence, but as you start to peel back the layers of the proverbial onion, you start to find out that, oh, maybe, we know the big stuff, which is the most important stuff, things like the EMR or EHR, things like certain maybe file servers or certain systems or applications. And the obvious stuff, well, that's obvious, right? But some of the other ways that that data is then used is maybe less obvious. We've seen a number of examples of IT being completely unaware of very robust business processes that were built up around emailing certain files that contain PHI. And that's not IT's fault or InfoSec's fault or compliance fault. It's an organizational fault. And it's only by kind of acknowledging that this stuff goes on that we'll make any headway. So this is, the fun graphic of a lot of organizations, especially when we first get engaged, they think that they have this great castle and this moat around it, and here's where our data is, and it's really hard to get to. What it ends up looking like when we, again, start peeling back the layers of the onion is Swiss cheese, because there's a lot of holes in some of those theories. And again, this isn't a finger-pointing exercise for us. This is the reality of how a lot of processes have grown up. It's not necessarily, health informatics fault or medical records fault. Some of the people might have been there for 20 years, but the way we did things 20 years ago, that's what made sense. That's what was the right business process to have. And most healthcare organizations haven't really taken any effort to engage the business. I'm not saying if you're in an IT role that you need to go out and start interviewing users, although it wouldn't be a terrible idea. But certainly if you're in an InfoSec role, if you haven't made the effort to get out and understand how are people using data, more importantly, how is it moving throughout the organization? And really, where does it end up? In what forms does it end up in things? And again, we can't just focus on some of the healthcare systems, but some of the support systems, some of the other systems that interact with them. It could be, something like a database or a file server. It could be something like email. It could be something like tablets and smart boards and things like that. So you have to kind of stretch that thinking beyond the EMR. A lot of times we get into some initial conversations with folks that we might not be directly working with yet, and there's this strong sense of let's just only focus on the EMR. And we can do that, and any consultant can do that. And it's not to say there can't be improvements in the controls within the EMR. There almost always can be. But if we restrict our thinking to only where we know the data is, and we don't kind of ask some of those tougher questions, we could be missing pretty large chunks of weak process. And time again, you know, when we have the opportunity to, we worked with pretty large healthcare organizations, large hospitals, medical groups, and it's pretty consistent. So some of the things I'll be providing throughout this are just hopefully helpful assessments or guidelines or recommendations. But you know, assessing yourself. Some questions to ask of your organization is, do you have all locations of PHI documented? How accurate is that documentation? Is it a diagram? Is it an Excel file? Is it, you know, literally notes on a piece of paper in the IT admin's office? We've really seen it vary pretty highly. Folks might, again, think they know, and it's easy to just draw a box around the EMR and say it's there, but the truth is actually very different in most cases. Ask yourself about users emailing ePHI. Are they doing anything like that? Because my hunch is they probably are. And you might have some great widgets in place, whether it be Barracuda or Blue Code or, you know, whatever you're using for email filtering and potentially email DLP, which we'll get into a little bit today. But you have to, again, ask about the process. There's clearly a business need for folks to do certain functions. And if you're not addressing that need with a approved solution, know that users are going to go to things like Dropbox or some other kinds of cloud services. Know that they're going to bring in removable media. Even the authorized places, like potentially file shares where certain groups and permissions are very restricted, or so we think. A number of times we've gone in and worked with folks and found that file server permissions weren't necessarily what they had been set to maybe 5 years ago when the new server was built. And that's not something that's on anyone's radar to revisit on an annual basis or on a quarterly basis or whatever the right cadence is for you. And really, have you challenged the business recently about how they're using that data? Again, we know mobile devices are showing up. We know USB sticks have been showing up for years and years. But talking to them about what they're doing with it and why they need to do it, that's something that you can go do today that's relatively inexpensive. It might require some resource commitment and maybe a day or two of time, but in the grand scheme of cost to your organization, that's not a whole heck of a lot. So when we talk about who's involved, the reason I bring it up is because if we start kind of calling out the players, we can maybe start tying together, or start understanding, I should say, a bit of the threats that each of those players might pose. So for things like common end users, and that I'll classify as doctors and nurses and admin staff, and there's certainly quite a few people depending on what flavor of healthcare you could be in. You could be in long-term care. You could be an insurance company. You could be a hospital, obviously. You could be an orthopedic practice. Wherever you're at on the spectrum, and there's certainly many more variations, you're going to have some sense of like a common end user. They're going to be the ones that show up. They're going to be the ones that are driving the business forward and pushing us technologically. You're going to have the technical end users, folks like your IT folks, your application development, maybe even specialized IT. We see a lot of biomedical engineering sometimes straddles the line between true IT personnel and their own department. Sometimes they really are their own unique department. Sometimes radiology has their own specific IT support staff because of some of the applications that they use. And those users are, again, going to be using data in a slightly different way. They might have reports that they generate. The application developers, and we'll touch on this in a couple of slides, but the application developers are very often writing interfaces between various systems. How is that data moving about? What about our application development processes? Have we really vetted how we're securing test data, for example? That's very often overlooked is, oh, well, you know, Matt Wilson has his dev system and he's pulling a snapshot of production. Was he ever sanitizing and normalizing that data? The answer very often is no. And usually by design, test systems have less control and little to no monitoring when compared to production. And then you have the obvious, the malicious attackers. That can be some of your state actors, like we've seen somewhat recently with China, and we'll touch on that. It could be a disgruntled employee. It could be a disgruntled former employee. It could just be someone out there in the ether that decides to attack your organization. And they have pretty obvious motives and threat vectors that they're going to try to exploit, right? Things like phishing and phone calls potentially, but really it's phishing emails or setting traps in various public forums to get people to do drive-by downloads and ransomware. So that kind of stuff I'm not saying is simple, but it is somewhat contained in terms of the threat vectors and threat scenarios. Then you have the public, which really in healthcare, again, depending on who you are, can be a huge X factor. I mean, most hospitals, right, are 24/7, and for the most part, it wouldn't be strange seeing someone walking around that other folks didn't know, even in admin-type areas. I end up in, not surprisingly, a lot of the IT admin areas in a lot of different, very large hospitals, and never once has anyone looked at me and challenged me and said, who are you, why are you here, who are you here to meet, whether I had a visitor badge on or not. For the most part, we just accept that these are very transient locations. And again, that's not to say shift everything and implement all these really strong physical controls, just that we have to accept that the public's going to be here. They're going to have access to things like a copier, potentially, that maybe that copier by default saves all the data that's scanned in it or copied through it to its hard drive or flash drive. And that copier is then in the public area or in a public area. And maybe a curious person from the public just walks by and sees what they can see, knowing that copiers store this kind of data. So those are the kind of non-obvious ways that the public might be a threat to us. And touching on some of what I just mentioned there about how data can just be available, I often use the term, very non-technical term, the data just wiggles out. And that's because it does. You know, information wants to be free, and that's the truth. This data is just going to kind of go in different places, and sometimes it's going to drive innovation, right? We want it to be so accessible. That's part of some of the evolution we're seeing in health information technology of all these applications are very data aware and geared towards sharing, and that's great. But we have to look at, you know, how users might be emailing or even faxing, and then the concept of e-fax and how that might impact us. What are those EMR, EHR systems, how are they transmitting data, either between themselves, potentially relationships and partnerships you have with other healthcare organizations? Let's go back to the paper. Let's not just focus on the electronic side of things, but very often nurses' stations are decently secured, but they have to make some trade-offs, right? I mean, they're in usually there's a hub and spoke model with the nurses' stations in most hospital environments, or even in long-term care facilities, there might be a nurse station head, and sometimes there's not a dedicated room that's lockable where we keep records. Sometimes it's left wide open, and maybe that nurse or the staff that man that post, maybe they walk away for a couple minutes to attend to an issue. So paper records could be moved or removed. And then we have the sneaker netting of data where we might pull it from one place and move it over to another via USB or CD and DVD are obviously less popular now, and even USB sticks are less popular. But we've even seen it. Sometimes auditors would come in, or again, some third parties that you might have relationships with, such as like a clearinghouse or insurance company. The file servers, and again, the permissions there. Any cloud services like, you know, Dropbox, and there's a million versions of Dropbox, but even Office 365. Have you considered, you know, a password compromise of one of your end users if folks in your environment are in the habit of emailing data about, and you think, oh, well, the cloud is secure and Microsoft's secure, or even before you were in the cloud and you were using something like Outlook Web Access, your Exchange server, well, my email server is secure. Fine, but what happens when you allow remote access to these applications and the user selects a bad password? Well, then it's only as secure as your weakest user, right? And if that user is doing anything within their email, it has to do with medical records, it could be exposed. even things like backupping and archiving data. Certainly tape is far, far less prevalent than it once was, still around here and there. But just think about some of the processes that could be exposing data through backup. Maybe you're, how you even decommission old systems and destroy old hard drives. We've had a couple of cases where folks have, taken hard drives out and left them in fairly public areas and relied on the fact that no one knew that they were there. We've seen cases of, staging areas for someone like an Iron Mountain or whomever is going to come pick up on some of your rotations for tapes or hard drives or whatever it might be. Some of the staging areas are less secure. So just think about in your environment how data could be wiggling out. But then we have how data is pulled out. And this is usually the threat vector that most organizations are really focused on. And it's valid. There is a huge uptick, and that's supported by FBI, it's supported by the breaches that have been reported in the news, as well as breaches that we're not even aware of in the public sector yet. But for sure, things like advanced persistent threats, and it does seem that, there are indications that state actors are at play here and targeting healthcare organizations in part of, I guess I'll describe it as like a drag net, where they're just kind of casting large nets out there and going after various healthcare organizations in hope of just building their own little set of dossiers on, whoever's been compromised. What their ultimate motive is, we can only kind of make some assumptions and guesses there, but it certainly is happening. And the ability to say, well, I'm not Anthem Blue Cross, I'm not that big, I don't have the same problems they do, we don't really have that luxury anymore. No matter who you are, no matter how big you are, you're potentially a target just by being in the healthcare industry. There is a focus for sure. And the other thing we've noticed is when folks are attacked and breaches occur, a lot of times we can attribute not the attack, but some of the weaknesses in the reaction is there's this over-reliance on tool sets, and we have these unrealistic, and my kind of silly term is magical expectations of how we're going to secure the environment. It's almost like if we go buy this widget and we implement it, we're secure. So we go and implement Logarithm as our SIM solution, and now we're done. We're set. We're secure now. We have our nice shiny next-gen firewall, and it's feeding whatever our SIM solution is, so we're secure now. And that over-reliance and overconfidence really works to an organization's disadvantage. And again, I'll caveat that statement with, I'm not saying the tools are useless, just that let's have realistic expectations of what the tools can do. Know that a determined attacker, just like whether it's your house, your vehicle, or your organizational data, a determined attacker has a very high probability of getting in and getting what he or she wants. So we have to kind of shift our mentality from that castle and moat to accepting that they're going to get in, and how are we going to detect and then react to such an incident. And a little bit more on the developer side of things, just like to take one moment, but it is a very unique challenge that we've seen time and time again. It tends to be in hospitals, less so in some other forms of healthcare organizations, like whether you're a manufacturer or, again, long-term care, which we have a huge client base on the long-term care side. But we see in a lot of hospitals, there's folks might be migrating to one kind of new EMR in some cases. Epic's one of the 500-pound gorillas, but there's certainly plenty more. But we've actually had a number of clients who have multiple EMRs, and sometimes that's because the physician's practice is preferred one versus the hospital preferred the other. Sometimes it's because of an acquisition. You might buy a new hospital or hospital group, and they were on Centricity, and you're on Meditech, or you're on Epic. There's all kinds of permutations that are available here, but in almost every case, there's someone or a group that does some kind of development. And I haven't met any organization yet that is really focused in on developers, their access to data, and their protection of data. And know that those interfaces are, using APIs that maybe the EMR or EHR provides to you. So I'm not saying they're insecure, But when we ask the questions that are pretty obvious questions, like is data being transmitted over SSL TLS? Very often IT and even the developers themselves have no idea because they're simply just using the APIs. So this isn't a condemnation of the EMRs or the developers themselves. Just like to highlight here that that's one of those areas that until you kind of think through the data, you might not really touch on the development side of things. Any questions thus far? I'll kind of pause for a moment to let folks collect their thoughts. I've kind of thrown a lot of content out there, but we can certainly keep moving along. Okay, great. And again, as we go, if there's something that comes up, please feel free to fire away. So from doing all these assessments and different work that we've done with healthcare organizations, know that you're not alone. Everything that I called out there, if that resonated with you, and even if it didn't, maybe it didn't, maybe we have met a number of folks that are doing quite a bit, have some really strong process, I should say. So their risk and view of those risks are different. But I can say that this is pretty ubiquitous. Just about everyone has some flavor of bad behavior. You know, it's the doctor that shows up with the iPad that wants to forward his hospital email to his personal Gmail account. I mean, we've had a bunch of clients that had that exact scenario. So if that resonated with you, know that you're not alone. If it didn't resonate with you, well, maybe ask yourself some tougher questions first, and then maybe you can say that I was wrong about your organization. But know that this is pretty common. And my personal theory on it is because a lot of healthcare organizations are still in the process of maturing their InfoSec programs. When we compare healthcare to financial, two of the most regulated environments, financial services organizations, banks, credit unions, various kinds of financial holding companies and things, there's a lot of information technology and IT security regulations that govern them. And I'm not saying they're perfect, but they're kind of used to it. They've been through the ringer many, many times over the years. They tend to be more secure. Whereas in healthcare space, because of HIPAA being passed in '96 and the regulators not really doing a whole heck of a lot until 2010, 2011, we had many, many years there where there wasn't a strong culture within healthcare of developing a mature InfoSec program. And I think that's improving. We've certainly seen a lot of interest and uptick in terms of resource allocation in healthcare, but it's still tough, right? Because we have to balance end user demands, our business requirements. Oh, and by the way, let's make it, quote, secure. And what secure means is a moving target based on the day and who you ask. So it's not easy. And we also have this unique challenge in healthcare where we have these patients that we have to keep alive and we have to treat, and there's all kinds of laws and regulations about how we have to do that. So sometimes we have folks that are making decisions that are truly intended to be in the best interest of the patient, but we're not soliciting input from someone that's a true InfoSec practitioner that might be able to give some different perspective on risk. So we might have a doctor that's not very well informed about IT or information security making decisions on a committee that directly influence that. And that's, again, that's just a reality that just about every healthcare organization has right now. And if you're thinking that I'm kind of nuts and that some of the threats are overstated, which I'm hoping not, but we can just look at some of the breaches that have made the news, some of the fines that have been issued by HHS OCR, and it's been around patching, encryption, access controls, logging and monitoring, amongst a number of other things. And if you are buying in and drinking the Kool-Aid, but your challenge is within your own organization selling it, well, the next couple slides are meant just for you. Breach impact, we've seen Anthem, Primera, within the last 12 months or so. A couple of others are in there, but the numbers speak for themselves, right? 80 million plus records with Anthem. Primera is over 11. CHS, which was 2014, had 4.5 million records. And sure, they're the big names that are getting all the bad press right now, and some folks at a high level in your organization might say, well, that's not us. We're never going to have the amount of data that Anthem has. And they might be right. But again, some more stats here, 141 confirmed incidents that resulted in data exposure in 2014. And the target was compromised in minutes in 60% of the cases there. So we don't have a lot of time to react. And when we look at even more recent and more potentially relevant data to you and your stakeholders, you can just go to the HHS, it's lovingly referred to as the wall of shame, but it's breaches that affect 500 or more folks, which are required to be reported. Most folks in healthcare know that, because usually if there's any concern about a data breach, usually the game becomes, well, is it 500 records? How can we get it to be under 500 records? Which, again, I understand the business reasons for that. But you know, this data was pulled on January 22nd, so a little over a week ago, and just there we can see the reported breaches really in the last couple of weeks. We have, what, 1, 2, 3, 4, 5, 6 or so that were in July through that date, and I'm sure there's even more on the site today. And we can see that, you know, one's 560 records. Okay, that's not really a huge amount of records, but, you know, 2 are over 7,000 records. And when we dig into the data even a little bit more, we see that through this year, and this is from the data from the Wall of Shame website, 94 million records in total exposed, 144 unique incidents. And if we took the top 10 incidents, those records that were breached, they range from 80,000 records to 80 million, which was obviously the Anthem breach. 50 breaches were over 5,000 records. So you can start to play the numbers. Again, if you're making your case to your stakeholders in your organization about the potential impact of a breach, you would know how many records you potentially have. Maybe you've been a hospital that sees 30,000 patients a year and X number of unique records. So let's just say you come up with 100,000 unique records for some reason. And you say, well, you know, if 10%, so 10,000 are breached, just multiply it out. You know, there's all kinds of studies out there about the cost of a breach. The Poneman Institute's a pretty good one. There's other, you know, data available for sure, but it's usually in the healthcare roughly $300+ a record. But even if that's all wrong, just take it at $100 a record, which is a very, very low estimate by most of the data that I've seen. Just play it out. You know, 1,000 records or $100 a record times 5,000 records. You know, could your organization sustain that kind of loss? But you can't necessarily tie directly to some of the costs. You have to think of the, you know, some of the direct costs. Think about the indirect costs. Think about the brand damage and so on. But there's even more than that data, right? If we just go back a little bit and analyze a larger data set, since 2009, 120 million unique people have been impacted by some form of healthcare data breach. That's a third of the U.S. population. And whether they realize it or not, you know, 90+% of healthcare organizations have had some kind of data breach in the last 2 years. And other data points to 125% increase in attacks on healthcare organizations. So I'll stop kind of reciting data, but I'm throwing it out there so that you are armed, or if you are a stakeholder or a key influencer in your organization, that, you know, if you're going to make decisions, have this weigh on you, right? Have this factor into your decision-making process. And there is this sense that, again, I'll reference back a couple slides where the concern isn't necessarily around focused data breaches where someone's coming after us, right? We think, that's unlikely to happen because really I'm worried about the endpoint and BYOD and folks kind of losing devices or being stolen. And the truth is, again, somewhere in the middle here, you can't ignore BYOD, and I'm not advocating that. But certainly, you know, all data points to criminal attacks going after healthcare data. And I think some folks earlier asked as to kind of the why. Why would folks do that? It seems to be for a couple of reasons. The state actors, again, it seems to be their motivation is building dossiers on folks, potentially reselling the data on some black markets. And ultimately what that results in a lot of cases is, you know, identity theft, some other kind of financial fraud like taking out loans, things of that nature. So it is potentially pretty damaging stuff, and I don't think you could ever know all the ways that data is being used, because once it's kind of out there, it's gone, right? That different communities of malicious users are going to use that in different ways, but it seems to be the state actors are kind of building dossiers on Americans, and the criminal underground is using it to profit in some way, and there's a number of instruments for them to do so. We have to recognize then that our controls that we've built today are really, or that we have built thus far through today, they're addressing the problems of the past. You know, we've enabled users through technology. That's fantastic. But if we haven't done so with baking that enablement into our InfoSec program, we're going to have some pretty glaring gaps in that, and we might not even realize it, right? Because we're trying to take HIPAA as it was written in 1996, and it's been updated over the years, of course, but take that, you know, take those requirements and apply it to today and how people work. We have to kind of update our thinking, right? So let's revisit our strategy. Know that first, compliance is not equivalent to information security. It's getting better, but a number of clients we work with are just worried about HIPAA compliance or PCI compliance, or in the banking financial services space, you know, they're only worried about compliance with GLBA or the NCUA or FFIEC, whoever it would be. No matter what regulations you're subject to, if you have a strong information security program, you're going to pull compliance into that. You'll be compliant as a natural outcome of having a strong information security program. But if you just try to be compliant, you will not have a strong information security program. None of the compliance regulations were written to help you build one. So accept that and acknowledge that and make sure you communicate that internally. Know that it's a process, that you can't, again, do some magical sequence of steps and then just be done. There's culture changes that we need to think about if we're going to be serious. We can't just go buy a bunch of widgets, put them in, and then expect it to be done. We have to change the way people think, and some of that's through awareness training, which is required by HIPAA, but some of that is just pulling people along with you. You know, if you're going to be the champion, you're going to need to build relationships and develop some other champions for information security. We have a number of hospital clients, again, that have folks that have been there for 30 years, and they're good people, but they fall into that trap of, well, this is just the way we've always done it, and they don't want to budge. I can't tell you how to get around those kinds of organizational politics, but what I can tell you is if you don't make any effort, you're going to be stuck exactly where you're at. And when you go get those widgets and, you know, go deploy the next-gen firewall or whatever you have, make sure that you fully deploy it and you're utilizing it before you go buy the next widget. We see a lot of folks that they're constantly chasing the next thing to be able to tick an audit box or to be able to justify some budget spend, but we're not looking at how we can better leverage. We had one hospital client in particular that spent quite a bit on their SIM solution, and only to find out, you know, a year and a half later that literally nobody was using it outside of one person in InfoSec. That the server, the virtual server that was deployed on, had about a quarter of the performance specs that were required by the SIM vendor, and that most of the log sources that would be useful, like firewalls and some key servers, were not even sending their log data to the SIM solution. That was 18 months after they had deployed it. So basically the last year and a half of any dollars they spent on this SIM solution was a complete waste of time. Because if they had had an incident in that time that really mattered, they would have gone looking for the data and found nothing. And it's, again, not until you start asking the questions about, well, what's configured and where does it go and who's looking at it and how are we using that data, how are we measuring, you're not going to figure that out. Again, accept that you'll be breached, right? Breaches are no fun for anyone, but accept that it's going to happen and accept that you probably won't pick it up. A great case in point here is that with the Primera breach, they first learned of the breach in January of 2015, earlier this year. But the initial indications, at least the last I've heard, the initial indications that they were breached, that breach probably occurred somewhere around May of 2014. That's somewhere in the lines of, right, 6 or 7 months where they were compromised and didn't know it. And again, before you fall into the trap of I'm not Primera, that's not going to happen to me, it's happened time and time again. If you haven't had a breach, it is that cliche of you've probably been breached but just haven't noticed yet, right? And that's not trying to scare you or anyone into a certain way of thinking, but it's just accepting the probable reality. So let's look at how the regulators have treated this. The good news is, or bad news, I guess, depending on perspective, but I'm an information nerd. So for me, when I actually heard that HHS, and just again, I should have had a terms slide here, but Health and Human Services, when they launched a pilot audit program in late 2011, I was actually excited, of course, because I'm a nerd. But from basically 2003, 4, or when the provisions of HIPAA really kicked in, until 2011, no one really knew what HIPAA was actually asking you to do. I mean, a lot of people said that they did. Even we felt that we did. But HIPAA was never, HHS I should say, was never really clear as to what they expected people to do with it. The law was actually very well written. It's something I do encourage, if you've never read it, to actually go read the security rule. It's very human readable. But outside of, it left a lot to interpretation, I guess is the best way to put it. So when they released this work program, or the pilot audit program, that ultimately resulted in the HIPAA audit work program, and there's even an iPad app, and there's a desktop app for Windows, if you're so inclined, available at the link below, it was great, because then they were very clear. This is what we expect you to do, and this is how we would test for such a thing. So again, that's good news to me, that they're being more clear. Now, I know it's a challenge for some organizations because now there's a whole bunch of extra stuff to do. But again, that's part of their reaction is, okay, let's accept that people are a little bit unclear here. Let's develop a work program and give that to them. Great. But how else have they reacted? Well, they have a number of case examples that they'll put up for those that have had failures to comply with the various HIPAA rules. And these are just two that have been in the last 12 months or so. And what's interesting here is that that St. Elizabeth Medical Center, the first one, where there's almost $220,000 fine, know that it was only the exposure of 498 individuals. So you can't necessarily go, and do the easy math, like I said before, and say 1,000 records exposed times roughly $100 a record or whatever it might be. Sometimes the fine that could come down afterwards could be quite substantial. It's going to have to be, and very often you're seeing, in the notes and write-up, is it's tied to how negligent they feel the organization has been. Another one was Cornell Prescription Pharmacy, a small organization, $128,000 fine, or $125,000 fine. It was about 1,600 records that were exposed through an open unlocked container, right? So these are real dollars that these organizations now have to put out that certainly are not in any kind of budget. So again, if you're looking for ammo, know that it's there. Another moment to just pause and say, are there any questions or something that anyone would like to spend a little bit more time on? Okay. Don't all speak at once, right? So in terms of rising to the challenge, right, what are we going to do now? So we've laid out this case of we all get that the breaches are real, the threats are real. What do we do about it? I can't stress enough, my game plan here, and what I'd recommend is your game plan if you're working within your organization, isn't just go scare stakeholders. Now, that might be a part of it, but if you just try to lead with the scare tactic, you're only going to get them so far. You really have to curry favor, you have to win them over, you have to help shift their thinking. And we can do that by sharing sharing some of the information we've provided today that's publicly available. There's a lot of other great sources and resources out there. And we want them to make more informed decisions, right? So that's part of rising to the challenge. The other part is, I can't stress enough, and I'm repeating myself here, but you got to ask yourself and your organization some tough questions. Would you know if you had a breach? What tool sets do you have in place? How quickly do you think you'd recognize the fact that you've had an incident? And how consistent is your response? Because again, it's not like HIPAA gives you an outline and a template for here's how you build an incident response plan. You just kind of need to have that in place. That's just the expectation. It's 2015. You need to invest in having such tool sets in place, whether it be on the intrusion detection side, whether it be on the policy, some of those administrative controls. And when folks look at solutions, they very often, just about everyone I know in IT goes right to the Gartner Magic Quadrant, and we do. When folks ask us about different solutions that are out there, we're not experts on every single one. There's a lot of players in the market. Various tool sets exist. So sure, do that as your first step. But know now, again, especially in 2015, there's a lot of overlap between different tool sets. Know that a lot of these vendors have kind of picked up other companies over the years, and now you literally can't just buy a firewall anymore. It has to be an intrusion detection system. It's plugged into real-time data that's pulling from points all around the world and updated every second, and those are all great things. I'm not, again, coming out against those. They're definitely advances that we need. But I want to call out that if you're going to just go to the Gartner Magic Quadrant and say that's all we need to consider, know that you're going to have to dig a little bit deeper. It's not that easy. You can't just look in that Magic Quadrant and identify a couple of solutions and say these are the three I want to work with. I mean, that's a starting point, but there's going to be a lot of overlap. So to kind of cut down on looking at 50 different things, think about how the solution is going to fit your environment, obviously, but be realistic about your budget. If you haven't budgeted for this, I won't say there's no point. You can always just kind of do your own reconnaissance and get a feel for what's out there. But if your organization hasn't budgeted, there's going to be a substantial spend here. It might be, in some cases, I'm sure you could make it as low as 10 grand, but usually it's in the tens of thousands, if not hundreds of thousands of dollars that you're going to need to invest. And that can be from an intrusion detection standpoint. That can be from a data loss prevention standpoint. So if you haven't budgeted for it, try to find ways like some of those next-gen firewalls that you might already have or be getting, or even something like Exchange 2013 that can do some limited DLP. Look at what you already have and try to leverage that. But most importantly, think about where you want these DLP tools, if you're focusing on DLP, where you want them to operate. You have email, you have the network, you have file servers, you have endpoints. There are specific tool sets just for that. There's email DLP, there's network DLP, there's endpoint. Just about every major, Symantec, McAfee, and so on, they have their own endpoint solutions, Trend Micro, that do some form of the data loss prevention, right? And really, let's just spend a moment talking about what that actually is. A lot of times, these are just algorithms that are searching through the data set to find a pattern. A pattern could be a social security number. A pattern could be a credit card number. But how do you codify what healthcare data is? Sometimes it's very, very easy. Sometimes it's a bit more difficult because of how the data is presented. And I don't know if there's any one single DLP solution out there that very well captures, what a healthcare record is. There's elements of that might exist and might be very good in specific use cases, but I'm sure we can poke holes in some of those. So again, I always encourage, don't just rely on the vendor speak, and don't just rely on one solution. You might want to operate, might want your DLP to operate everywhere across email, network, file, and endpoint. And that might be a whole other set of solutions. So it's complicated, and I can't in a vacuum recommend just go buy this, right? There's a lot of good vendors that work in that space. Know that they can add capability, but you got to be fair with your expectations. Don't expect that you're going to go implement this solution and all of a sudden you're going to have a solid data inventory. You're going to get some good data, but that tool only knows what it can see. So unless you've gone out and conducted some of those meetings and interviews, you're not going to have the context to know how people are working or how they want to work, to know some of the potentially bad behaviors that they're doing. So you might implement a good email DLP solution, and it might be great at finding credit cards, but is it going to find in an Excel sheet strewn across multiple subsheets, the PHI or EPHI that lives in there? Probably not. It might have some, again, heuristics that it applies and might turn you on to potential things to investigate, but the signal-to-noise ratio there is going to be very, very high. So again, just know that going in, that you're not going to be able to just go buy one solution. Some other considerations that we see folks constantly struggle with are, who's going to own this thing once it's here? And as obvious as a question and a statement as that sounds, we really see it taking three major forms. Now, there's other forms for sure, but folks that just say, all right, I'm going to go buy this widget, again, whether it's a DLP solution, a SIM solution, whatever the security solution of the day is, and one lone admin is going to take care of that. It's going to be someone in IT. We don't even have a dedicated InfoSec person. Well, then know that you're going to be providing yourself with very limited capabilities. 24/7 by 365, that goes straight out the window when it's one person. And that specialization of knowledge, that's going to be something that they have to develop. If they're and I don't mean to disparage anyone, but if they're a typical IT admin, whether on the server side or network side, they're not going to have the InfoSec nerd's mindset to really dig in, right? So if you're just going to say, we're going to go buy this DLP solution or SIM solution or intrusion detection solution at a cost of $300,000 with $150,000 a year that we got to renew in licensing and so on, and then you're going to staff it with effectively a half of an FTE, that's a bad spend. I'd say invest that money differently then, or make a compromise with your solutions, cut down on the big spend, and staff what you're going to actually bring into the environment. Another variation we see is we might have a dedicated InfoSec team. Sometimes that team is an army of one. Sometimes it's a small team. There you're going to pick up some more capability, but again, do you have a SOC that's staffed 24/7 by 365? Very few organizations are building out. We have a couple healthcare clients, usually the larger hospital networks, that are actually developing that. But it's few and far between. Now, I can count on one hand the number of customers I know that are either doing it or even considering it. So very, very few. And then there's the managed service, which has been the name of the game for the last 5 or 6 years or so, right? Cloud, managed services. There's some more robust capabilities there, but you're going to get, I'll call it, unknown quality because you might not have worked with said vendor. And that's not to knock any particular vendor or promote a particular vendor. But their focus a lot of time isn't going to be on the data loss prevention side necessarily, more on intrusion detection and incident detection. We actually just had a recent interaction with one of our larger retail clients in the Wisconsin area, and their InfoSec group had a pretty refreshing take on things. They were a pretty lean and mean team, but a pretty large retailer. And they said, look, we know we're not going to get the staff that we need, so we're going to manage our managed service vendors. That's what I'm developing my team to do. So their director of InfoSec actually had a pretty interesting take on it. He has some really good processes. I can't say his approach would work everywhere, but it really was an interesting discussion. And that's an organization that I can't say has figured everything out, but really is on the right path. They've accepted what they can spend. They know it, and they've decided to go the managed service route to get some increased quality at the cost of, maybe having the full control that some organizations might want. And then we have the role of the electronic medical record system. A lot of times what we see, and folks have just kind of assumed that the EMR is secure. And again, that's kind of a silly statement because nothing is just done and secure. Security is fluid. And know that these EMR applications are relying on some really imperfect controls. Yeah, there's some access control and there's some audit logging and monitoring and such in there, but I haven't found anyone that has that really vetted very well. There's granular access controls in there, but has your organization created formalized, documented roles for a nurse, for a ER nurse, for a, the various, my brain is failing me at this point, but there's a lot of permutations of different kinds of roles in some of these organizations. Have we documented specifically what access that they need, access within the EMR application that those groups need? Very often the answer is no. The capability's there, but we usually just clone Matt Wilson. He's in this role, so we just hired someone just like him, so just clone that user. That's again, that's old thinking for old process. We need to take a whitelisting approach to say, here's the minimum baseline configuration that we're okay with, and then we add and explicitly authorize. And on the audit logging and monitoring side, you can detect inappropriate activity. Sure, everything is logged in modern EMRs. If you're running anything in the last couple of years, you know if you've ever trolled the log data, which I've had an opportunity to in both Epic and Citricity and a handful of other, Meditech Meta and a handful of other EMRs, there's a lot of info there, obviously. It's everything that's ever being done within that application. So what are most people doing? They're just relying on humans to troll through that data and find the fraudulent activity or potentially unauthorized activity. While that is better than nothing, taking a sample absolutely is a good control, I can't hang my hat on the fact that that's going to catch all inappropriate activity. And you're seeing that Epic recently formed some relationships with some data analytics companies to help get a sense of what normal is, and I'm sure other EMRs are doing the same. So that's not necessarily like me plugging Epic. I don't have any relationship with them, but just know that it does seem to be something that the EMR vendors are paying a bit more attention to. So if you're feeling that pain, again, know that you're not alone. And the thing is, with the security monitoring side, ask yourself how it's currently being achieved. Again, are you doing some kind of sample? How are you capturing that data? Where is it stored? Are we sending it to a syslog server? Is that backed up in archive? There are some explicit HIPAA requirements at play here, but for the most part, we're relying, again, on those manual processes. So in terms of next steps, if you want to walk away from today, and hopefully I'm enabling you a bit, but if you haven't already, if you haven't caught it already from me, get out there to some of your user base and talk to them. Talk to them about how they're interacting with technology. Ask them what data they use, what applications they use, how the data moves around. Are they aware of all the risks of any kind of sensitive data that they have? I had a recent long-term care client where we asked not necessarily about HIPAA data, but we actually happened to be doing an assessment, and we walked by the marketing department. And I just said, oh, marketing doesn't have anything sensitive now, do they? And they said, oh, I don't know. This was my contact was the IT director. And so we just happened to stop by in marketing and kind of grab their ear for 5 minutes informally, and we just asked and said, hey, is there any, what data do you guys have? And they said, we actually use this application because they're a long-term care facility. They're trying to market to potential future residents in the area. They've actually subscribed to a service that pulls down all kinds of sensitive data. So this isn't their data in the sense that this is about their existing residents. This is potential target data or potential prospect data for them. But it was full SSN, name, address, phone number. It was very detailed data that's just stored on a marketing workstation. This was something completely unknown to IT. They had no idea what was going on. So again, this isn't anyone's fault. This is just marketing doing what they need to qualify the targets and potential marketing activity they're going to do. But until you go out there and get that, ask that question, you're not going to know that. Document the location and nature of your PHI. I love seeing diagrams. I love seeing Excel documents where we have server names, and most organizations in IT, they have a server list that's often in Excel. But have a column that says PHI and have there be an X or a yes or a no or whatever. But there's some special considerations in healthcare. You might have a health informatics department, medical records, biomed. CMIO is a new Chief Medical Information Officer role. That's relatively new to some organizations. Again, application development. Think about how you're storing records off-site. We've seen a couple of instances. Tends to be less in like the larger hospitals and healthcare networks, but some of our, again, long-term care facilities, behavioral health, they might have a facility that's a couple miles away that has extra storage space in the basement, so they take up a bunch of boxes and drop them there. Well, that's not, the security is just a key lock on the door to that closet. And then basically everyone in the organization forgets about the data the second that it goes there because it's for archiving purposes. So again, just kind of track your data, follow it through. Start evaluating some of your key InfoSec processes, like how you're doing security monitoring. How would you know there's an incident? How would you detect unauthorized access of records within your EMR? And is that, how valid is that? How consistent is that? How good are you at incident response? Vulnerability management. How are you validating and testing your controls? Are you doing an annual pen test, or have you done some kind of security assessment, whether you do it by yourself or you engage a third party? Get out there and do these kinds of things and look at how you can enhance your existing tool sets around intrusion detection and data loss prevention. but don't just go buy a widget for the sake of buying a widget. Go out there and support it in the right way. So quick recap, says we're right at 12 o'clock on the East Coast here. Look, data is leaving your environment. There's various ways it can be. Some of them we touched on. There's probably ways I don't even know about yet. But there's no silver bullet here. It's people, process, technology. You got to get all of them on board, working together. And it's not perfect, right? You're never going to achieve 100%. But it's about knowing where your weaknesses are, having a game plan, a corrective action plan in HIPAA and HHS speak, having a corrective action plan in place that you're working on to get you better. Not done, not 100%, but just better. And then, again, supplement those widgets that you have with yourselves or other stakeholders in IT or information security interacting with your end users. You want to understand how they work and how they want to work, because that's going to allow you to think through the potential scenarios that data could be walking out, specific to your organization. So, all that said, that was about an hour or so of content. I certainly have some time for any questions or follow-up. Please feel free. It's been relatively quiet for most of the presentation, and I don't think we've had any additional questions come in. But anyone on the webinar, firstly, thank you. But I will certainly hang around for a couple minutes if there are any questions and anything folks want to chat about. Oh, thank you, Deb. Very kind of you to share that. Glad you enjoyed it. Great. Thank you, Stacy and Max. Yep. Everyone, thank you for attending. So, yeah, please, Anna and I'll probably hang on for another 5 minutes or so. So feel free to fire away. And there's my contact information if you want to reach out directly.